In the cardiovascular type of exam, again, we're starting up at the neck. We're looking for any jugular venous distension, because if there's some kind of backward flow from the myocardium and the cardiovascular system, it would cause it to flow backwards. And if it's not going forward, flow out through the aorta and left ventricle, this would lead to some congestion and backup in the venous system identified in the jugular vein. So jugular veins are looked for up here. We may end up looking at the chest wall to see if there's any surgical scars for any type of implant devices, such as a pacemaker that may be placed here. And there also may be an AICD or other kind of surgical markings. For example, maybe a coronary artery bypass graft, where the person has a scar just right down the sternum, where they've opened them up to do a type of bypass over the blockages of the right and left coronary artery, or whatever artery that was obstructed. As we go down through the cardiovascular exam, we are also listening to their heart sounds. And at this particular time, it doesn't necessarily mean that you have to know them, but up here on the second intercostal space at the right sternal border, we're listening to the aortic. If we listen across on the left sternal border, just across where we listened before, we're listening to the pulmonic exchange. So as the blood's coming out from the right ventricle, coming out through the pulmonic valve, as we come down, we can listen to the tricuspid valve, and a little bit lower towards the apex almost, we can hear it for the mitral valve. And then over the apex of the heart, where the myocardium is the largest, the left ventricle sits the biggest, we can hear a lot of that S1 and S2, which is the closure of your mitral and tricuspid valve as the ventricles push out and force blood outwards. The second closure sound, that S2 sound, is the closure of the aortic and pulmonic valve as the pressure in the ventricles become more normal and equalized, I would say, to the pressure of the circulatory system or vasculature. This pressure gets a little higher in the vasculature, and that will cause that backward pressure as also the ventricles dilate and relax. It'll cause the closure of the valves, the aortic and pulmonic valve. That's your S2 sound. So as we listened and looked to the upper torso, this coronary or cardiovascular exam, then we would check the lower extremities to see if there's any bilateral pulmonary edema. We can go ahead and get our blood pressure and test our pulses. We're going to be checking our peripheral pulse and more central pulse to compare the differences in intensity, quality, rate, and rhythm. If there's any irregularity, this would be time where we would also deploy our EKG monitoring. So we're looking for any type of arrhythmia or extra beats or extra systoles. With the EKG, we're going to be putting on our limb leads, which connect across the upper torso and then down to the lower torso. And then we may even put on the precordial leads, which is our 12 lead that goes across the front anterior portion, mostly towards the left. We also can go over to the right side, checking the right ventricular, and then we can continue on the posterior aspect to look at the more of the posterior wall findings and our 15 to 18 lead EKG. But the normal EKG that we put on are just the limb leads, 2, 3, AVF, leads 1, 2, and 3, and the augmented leads, AVR, AVL, AVF, and then we can take a look at those. Our blood pressure, when we're doing our cardiovascular test, we can check our blood pressure in a supine position and do orthostatics to check homeostasis and orthostasis. If their blood pressure is low or if there's a volume problem, as we sit them up into a sitting position where we bring the feet down towards the side and they're totally sitting here in a sitting position, we'll check the blood pressure after a few minutes of them equalizing, and then if their blood pressure has no change and they're feeling okay and they're not reporting any type of weakness or feeling lightheaded or faint, we can go ahead and stand them up to an erect posture where they're fully standing with feet on the ground, standing straight up. Again, we're recording heart rate and blood pressure, and this one's we want to check a systolic and diastolic blood pressure to see any changes. Now, when we check for orthostatics, we're looking for an increase in heart rate of about 20 points, and we're looking for a drop in the systolic pressure of about the same. So you're gonna see some books that say a 10-point drop in blood pressure, 20-point up in heart rate. If you see a 10-point drop in heart rate, blood pressure and a 10-point increase in heart rate, you could say that the person is trying to compensate. Heart rate's going up, blood pressure is coming down, and they're unable to maintain that homeostasis. At any point, if the patient also complains and is symptomatic and feels lightheaded during this orthostatic blood pressure check, it should be noted and potentially that person's blood pressure or orthostasis is a positive to check, and that we don't need to continue to keep them upright any longer. So we will forego taking that blood pressure and just lay them back down so that we can return blood and circulation back to the heart and the brain. Don't forget to check the skin color. So we ought to also check the conjunctiva under the eyes, the oral mucosa and gingiva. We check for skin turgor. This may be pinched on the top of the head. We can check for skin turgor on the back of the hands. We can check for the capillary fill